the thoracic spine and thoracic pathologies. Please note that this is the last section of our class together. Our final exam will encompass the thoracic spine and thoracic pathologies and breathing, as well as major topics from the entire semester. The final exam is comprehensive, so I would encourage you to start studying the study guides from each section to help prepare for the final exam. The final exam is scheduled for Thursday, December 13th from 8 a.m. to 10:30 a.m. and is worth 150 points. Today we will cover the first 35 slides of the lecture, so here we go. The thoracic spine is the longest region in the spine, and by some measures it's the most complex. Connecting with the cervical spine above and the lumbar spine below, the thoracic spine runs from the base of the neck down to the abdomen. It is the only spinal region attached to the rib cage. Thoracic spine pain, or pain in the upper and mid-back that corresponds to the area of the rib cage, is not nearly as common as low back pain or neck pain. But it occurs fairly frequently, particularly in young people, older people, and in females. Thoracic spine pain affects up to 35.5% of the population per year, according to a 2009 systemic review. The review also found that teens may be prone to thoracic spine pain. The reason for this was backpack use. Textbooks and other things that go into students' backpacks can get pretty heavy, so watching for this risk factor in a child may be a good idea in the future. The osteology of the thoracic spine. We'll start with the sternum. Remember that the sternum is made of three parts. The upper part is the manubrium, the middle part is the body of the sternum, and then the bottom is the xiphoid process. The vertebrae of the spine, I always think about the times of the day that I eat to remember how many vertebrae are in each section. We'll start from the top. We eat breakfast at 7 a.m., so there are 7 cervical vertebrae. We eat lunch at noon, so there are 12 thoracic vertebrae, and we eat dinner around 5. So there are 5 lumbar vertebrae. Your first thoracic vertebrae represents the place where your neck ends and your rib cage area begins. It is located approximately at the level of your shoulders or just a little above. Your 12th thoracic vertebrae corresponds to the bottom of your rib cage. There are 12 rib pairs in all, and in the back, each attaches to one vertebrae and articulates with the sternum in the front via costal cartilage, except for ribs 11 and 12, which do not articulate with the sternum. So T1, which is your first thoracic vertebrae, provides a place of articulation for the right and left first rib. T2 provides a place of articulation for the second ribs, and so on down the line. The lowest or last ribs connect to T12, which is also the last bone in the thoracic spine. The ribs are described based on their location and connect with the sternum. All ribs are attached to the thoracic vertebrae and are numbered accordingly, 1 to 12. Ribs that articulate directly with the sternum are called true ribs. False ribs connect indirectly via cartilage. Floating ribs, ribs 11 and 12, are not attached to the sternum at all. Because the thoracic region is large, it is often divided into upper and lower areas for diagnostic and communication purposes. Each rib consists of a head, neck, and a shaft. The head of the rib is the end part closest to the vertebrae, in which it articulates. It is marked by a kidney-shaped articular surface, which is divided by horizontal crest into 2 articulating regions. The upper region articulates with the inferior costal facet on the vertebrae above, and the larger region articulates with the superior costal facet on the vertebrae with the same number. The transverse process of the thoracic vertebrae also articulates with the transverse costal facet with the tubercle of the rib on the same number. The crest gives attachment to the intra-articular ligament. The neck of the rib is the flattened part that extends laterally from the head. The neck is about 3 centimeters long. On the posterior surface at the neck is an eminence, the tubercle, that consists of an articular and non-articular portion. The articular portion is the lower and more medial of the two and presents a small oval surface for articulation with the transverse costal facet on the end of the transverse process of the lower of the 2 vertebrae of which the head is connected. The tubercle is more prominent in the upper ribs than in the lower ribs. The angle of a rib, or the costal angle, may both refer to the bending part of the rib and the prominent line in this area, a little in the front of the tubercle. This line is directed downward and laterally and gives attachment to the tendon of the iliocostalis muscle. The distance between the angle and the tubercle is progressively greater from the 2nd to the 10th ribs. The area between the angle and the tubercle is rounded, rough, and irregular, and serves for attachment sites of the longissimus dorsi muscle. The sternum is a long, flat bone forming in the middle portion of the front of the chest. The top of the sternum supports the clavicle or collarbones, and its edges join with the costal cartilages of the first 7 pairs of ribs. The sternum consists of 3 main parts: the manubrium, the body, and the xiphoid process. In its natural position, the sternum is angled obliquely, downward and forward. It is slightly convex in the front and concave from behind. In adults, the sternum is on average about 17 centimeters long. It's longer in males than it is in females. The sternal angle is located at the point where the body joins the manubrium. The sternal angle can be felt as the point where the sternum projects furthest forward. However, in some people, the sternal angle is concave or rounded, which we'll talk about in this presentation. During physical examinations, the sternal angle is a useful landmark as the 2nd rib attaches there. The sternocostal joints, also known as the sternocondral joints or costosternal articulations, are synovial plane joints of the costal cartilage of the true ribs articulating with the sternum, with the exception of the first rib, which is a synarthrosis joint, since the cartilage is directly united with the sternum. The costochondral joints are the joints between the ribs and the costal cartilage in the front of the rib cage. They are hyaline cartilaginous joints or synchondrosis joints. Each rib has a depression shaped like a cup that the costal cartilage articulates with. There is normally no movement at these joints. Joints between the costal cartilage of the 6th and 9th rib are plain synovial joints. The interchondral articulations are joints formed between the costal cartilage of the ribs. The contiguous borders of the 6th, 7th, and 8th, or sometimes of those of the 9th and 10th, costal cartilages articulate with each other by small, smooth, oblong facets. Each articulation is enclosed in a thin articular capsule lined by a synovial membrane and strengthened laterally and medially by ligamentous fibers, which pass from one cartilage to another. Sometimes the 5th costal cartilage, more rarely the 9th and 10th, articulate with their lower borders with the adjoining cartilages by small oval facets, although more frequently the connection is by a few ligamentous fibers. Each thoracic vertebrae articulates with a pair of ribs at facets or small depressions on the vertebral body and transverse process, except for T11 and T12. Most of the thoracic vertebrae share various anatomical characteristics. However, T1 somewhat resembles the last cervical vertebrae, or C7, and T9 through T12 progressively look more like the lumbar vertebrae. So, the thoracic bone markings. Each has a body, which is a cylindrical mass on the anterior side of the vertebrae. It articulates with the vertebral bodies above and below. There is a vertebral foramen, or the spinal foramen, which is a large opening in the center of the bone which forms a passageway for the spinal canal and the spinal cord. The vertebral arch, or the neural arch, which is made up of the 2 pedicles, the 2 lamina, and the spinous process. The arch encloses the posterior vertebral foramen and protects the spinal cord. A pedicle of the vertebral arch is a posterior extension from the lateral side of the body. The 2 pedicles form the base of the vertebral arch. The lamina of the vertebral arch is a plate of bone that extends from the pedicle. The 2 lamina form the dorsal portions of the vertebral arch. A spinous process is the downward posterior projection from the junction of the two lamina. It is long and narrow and has an expanded tip. Ligaments and muscles that move the vertebral column attach and originate here. The transverse process is a thick elongated projection that extends lateral posteriorly from the junction of the pedicle and the lamina. It serves as an attachment point for several back muscles. The superior articular process is the superior projection near the junction of the pedicle and the lamina. The associated facet is flattened, faces backwards, and articulates with the inferior articular facet on the vertebra above. The inferior articular process is an inferior projection from the anterior surface of the lamina. The associated facet is flattened, faces forward, and articulates with the superior articular facet on the vertebrae below. So, when we're looking at the vertebrae, sometimes it can be difficult to know which one is which. We have on this slide 5 different vertebrae. We have a lumbar, a cervical, a thoracic, the atlas, and the axis. The atlas has a transverse foramen and is ring-shaped. Cervical vertebrae number 4 has a transverse foramen, small body, bifurcated spinous process, and no transverse process. Cervical vertebrae C7 has a transverse foramen, a small body, and a prominent spinous process. Thoracic vertebrae number 6, or T6, has a transverse process at about 45-degree angle, has costal facets, facet joints in the frontal plane. And then the lumbar, or L4 vertebrae, has a transverse process at about 90 degrees, has a large body, facet joints in the sagittal plane. Here are the labels for each of these: the lumbar, the cervical, thoracic, the atlas, and the axis. The costotransverse joint is the joint formed between the facet of the tubercle of the rib and the adjacent transverse process of the thoracic vertebrae. The costotransverse joint is a plane-type synovial joint which, under physiological conditions, only allows a gliding movement. The costotransverse joint is present in all but the 11th and 12th ribs. The first 10 ribs have 2 joints in close proximity posteriorly, the costovertebral joints and the costotransverse joints. This arrangement restrains the motion of the ribs, allowing them to work in parallel fashion during breathing. If a rib only had 1 joint posteriorly, the resultant swivel action would allow the rib to be non-parallel with respect to neighboring ribs, making for really inefficient breathing. In this image, we can see the costotransverse joint. We also have a costovertebral joint. The costovertebral joint is the articulation that connects the head of the ribs with the bodies of the thoracic vertebrae. The joining of the ribs to the vertebrae occurs at 2 places, the head and the tubercle of the rib. The joints of the thoracic spine. Within the intervertebral body, there is an intervertebral disc space. This disc lies between the adjacent vertebrae in the vertebral column. Each disc forms a fibrocartilaginous joint, or a symphysis, to allow for slight movement of the vertebrae and acts as a ligament to hold the vertebrae together. The disc's role is as a shock absorber in the spine and is crucial to movement. The facet joint is also known as a zygophyseal or apophyseal joint and is a synovial joint between the superior articular process of one vertebrae and the inferior articular process of the vertebrae directly above it. There are 2 facet joints in each spinal motion segment. The facet joints are situated between the pedicle and the lamina of the same vertebrae and form the articular pillars that act to provide a structural stability to the vertebral column as a whole. Together with the discs, the bilateral facet joints transfer loads and guide and constrain motions in the spine due to their geometry and their mechanical function. These structures make up the thoracic segment of the body. These are anterior and posterior images of the thoracic cavity. The biomechanics of the rib cage can affect the entire spine and the extremities. The diaphragm and the movement of the rib cage is also affected by venous and lymphatic drainage back to the heart. There are 4 types of rib motion that we'll talk about. The first is the pump handle. This is a movement of the ribs that results in the change of the anterior-posterior diameter of the thorax. One of the most important functions of the ribs and the diaphragm is the change in volume of the thorax, which helps with inspiration and expiration. In general, the ribs move around 2 axes. The anterior end of the rib is lower than the posterior end. Therefore, during elevation of the ribs, the anterior end also moves forward. Movement at the costovertebral joints, 2 to about 6 on the same side of the axis, results in a raising and lowering of the sternal end of the rib, the pump handle movement. This pump handle action occurs mostly in the vertebral sternal ribs. In elevation, this increases the anterior-posterior diameter of the thorax. The bucket handle is a movement of the ribs that results in a change in the transverse diameter of the thorax. The anterior end of the ribs is about 4 centimeters lower than the posterior end, and the middle part of the rib is lower than the anterior and posterior ends. Movement at costovertebral joints 7 to 10 about an anterior-posterior axis results in raising and lowering the middle of the rib, which results in the bucket handle movement. In elevation, this increases the transverse diameter of the thorax. Another rib movement is the Caliper action and occurs at ribs 11 and 12. This movement is like an ice tong and increases the lateral diameter of the ribs during inspiration. Ribs are flexible and twist from their original shape. This is needed since each rib articulates with 2 vertebrae, and those vertebrae do not stay in the same position relative to each other as we move. When the vertebrae above rotates to the left side, it takes the top half of the rib with it, but not the bottom half. The rib is still attached at the sternum, which is not moving the top of the rib differently from the bottom half. It is holding the front of the rib while the vertebrae twists or places a torque from the back. The opposite-sided rib will be torsioned in the opposite direction. Both ribs should regain their original shape when the vertebrae return to a neutral position. But these movements all do not occur alone. The ribs move with a combination of each of these movements. Ribs 1 through 10 all have pump and bucket handle motion. Even with caliper motions of ribs 11 and 12, the ribs still elevate with bucket handle motion. These are physiological motions, and if a rib becomes restricted in one direction of motion, it is dysfunctional. Dysfunction at one rib can affect the motions of other ribs in the region. For example, if a rib gets stuck down, where it would be with breathing out, then the rib below it will be stopped as they try to elevate with breathing in. If a group of 4 ribs will not elevate normally in their pump and bucket handle motions, the top rib is causing the problem. It is the dysfunctional rib. This is like a line of 4 people walking across a room. If the first one stops, the other ones behind must stop as well, because they're running into the person in front. The diaphragm is a dome-shaped muscle and membranous structure that separates the thoracic or chest cavity and the abdominal cavities in mammals. It is the principal muscle of respiration. It originates from 3 areas. It has a vertebral origination from the chorea of the body's L1 and 2 on the left and L1 through 3 on the right. The costal origin comes off the cartilage of ribs 7 through 12. The sternal origin is on the xiphoid process and all insert into the central tendon. The diaphragm is innervated by the phrenic nerve, and its action is to contract during inhalation, it provides trunk stabilization, and it relaxes on exhalation. Contraction of the diaphragm increases the internal height of the thoracic cavity, thus lowering its internal pressure and causing inspiration of air. Relaxation of the diaphragm and the natural elasticity of lung tissue and the thoracic cage produces expiration. The diaphragm is also important in expulsive actions, for example, coughing, sneezing, vomiting, crying, and expelling feces, urine, and even during pregnancy of fetus. The diaphragm is pierced by many structures, notably the esophagus, aorta, and the inferior vena cava, and is occasionally subject to herniation or rupture. Small holes in the membranous portion of the diaphragm sometimes allow abnormal accumulations of fluid or air to move from the abdominal cavity, where pressure is positive during inspiration, into the pleural spaces of the chest, where pressure is negative during inspiration. Spasmodic inspiratory movement of the diaphragm produces the characteristic sound known as hiccuping. The external intercostal muscles are responsible for forced and quiet inhalation. They raise the ribs and expand the chest cavity. They originate on the interior border of the rib above and insert onto the superior border of the rib below. The internal intercostal muscles are responsible for forced exhalation. They originate off of the superior border of the rib below and insert onto the inferior border of the rib above. The transversus thoracicus muscle lies internal to the thoracic cage anteriorly and is a thin plane of muscle and tendinous fibers that is situated upon the inner surface of the front of the chest wall. It is in the same layer as the subcostal muscles and the innermost intercostal muscle. It originates off of the inferior body of the sternum and the xiphoid process and inserts into the costal cartilage of the 2nd through 6th ribs. Its action is to depress the ribs and help with exhalation. This muscle is almost completely without function, but it does serve to separate the thoracic cage from the parietal pleura, and it depresses the ribs. Contraction of this muscle aids in the exertional expiration by decreasing the transverse diameter of the thoracic cage. The serratus posterior superior is a thin quadrilateral muscle. It is situated at the upper and back part of the thorax, deep to the rhomboid muscle. It originates off of the nuchal ligament, then the spinous processes of C7 through T3, and inserts into the superior border of the 2nd through 5th ribs, and it elevates the ribs during inhalation. The serratus posterior inferior is situated at the junction of the thoracic and lumbar regions. It is in a regularly quadrilateral form, broader than the serratus posterior superior muscle, and separated from it by a wide interval. The serratus posterior inferior originates from the spinous processes of T11 through L2 and the thoracolumbar fascia. It inserts into the inferior border of the 9th through 12th ribs. The action is to depress the ribs during exhalation. The process of inspiration and expiration are vital for providing oxygen to tissues and removing carbon dioxide from the body. Inspiration occurs via the contraction of muscles, such as the diaphragm, where expiration tends to be passive at rest. This process changes slightly when breathing is forced. The lungs and breathing. The lungs are enveloped in a parietal and visceral pleura, and the space between the lungs and the thoracic wall is called the pleural space. This is usually filled with pleural fluid, which forms a pleural seal and holds the outer surface of the lungs against the inner surface of the thoracic wall. This ensures that when the thoracic cavity expands or reduces, the lungs move with it due to its surface tension of the pleural fluid forming within the pleural seal. Therefore, the contraction and relaxation of certain muscles during breathing causes movement of the lungs, which changes the volume of air within the lungs. Boyle's law states that when temperature is constant, the volume of gas is inversely proportional to pressure. Therefore, when the lungs expand, increasing the volume of air within them, pressure declines. When the pressure of the air outside the lungs is greater than the air inside, air will rush into the lungs, and vice versa. Inspiration allows air to be moved into the lungs and requires the contraction of various muscles. The diaphragm and external intercostal muscles contract. When the diaphragm contracts, it flattens, pressing down on the abdominal contents and lifting the thoracic cavity. This leads to an increase in the volume of the thoracic cavity. The diaphragm is the most important muscle in inspiration, as it amounts to about 60 to 80% of the work in ventilation. Contraction of the external intercostal muscles leads to an elevation of the ribs and the sternum. These actions cause an increase in the volume of the lungs. According to Boyle's law, an increase in the volume of air results in a decrease in the pressure of the air within the lungs. Pressure outside the lungs is larger compared to the inside, and air rushes into the lungs as gas molecules move from an area of high pressure to an area of low pressure. During passive expiration, expiration allows for the removal of air from the lungs and at rest is passive, relying on elastic recoil. The diaphragm and external intercostal muscles relax and return to the resting position. The elastic recoil of the stretching lungs causes them to recoil back to their original volume rather than due to an active movement. Due to Boyle's law, a reduced volume of air leads to an increased pressure of air within the lungs. When the pressure within the lungs is greater than the outside, air rushes out of the lungs as gas molecules move from an area of high pressure to low pressure. Forced breathing requires active inspiratory and expiratory effort with the help of accessory muscles. Forced inhalation is similar to normal inspiration, in which the diaphragm and external intercostals contract, but also requires effort from the inspiratory accessory muscles, such as the scalenes, the sternocleidomastoid, pectoralis major and minor, serratus anterior, and latissimus dorsi. Forced expiration, on the other hand, unlike normal expiration, is an active process. It involves contraction of the abdominal muscles, which force the diaphragm upwards, reducing the volume within the thoracic cavity. It also requires contraction of the internal intercostal muscles and innermost intercostal muscles, which pull the ribs downward. Both of these actions contribute to a decreased thoracic volume, and pressure is inversely proportional to volume. Therefore, pressure within the lungs increases, forcing the air out quicker than normal expiration. The phrenic nerve innervates the diaphragm. The phrenic nerve originates from C3, C4, and C5. The phrenic nerve can become damaged and will result in a paralyzed diaphragm. Remember that the diaphragm is responsible for about 60 to 80% of the effort for inspiration, which means that individuals are going to have a difficult time getting air in. Causes of a phrenic nerve palsy include mechanical trauma, which is ligation or damage to the nerve that typically occurs during surgery. Compression, for example, by a tumor in the chest cavity. Myopathies, such as myasthenia gravis, or neuropathies, such as a diabetic neuropathy. Phrenic nerve palsy is not overly common. This is an example of an X-ray of someone who has phrenic nerve palsy. This is a paralysis of the right side of the hemodiaphragm. The thoracic spine evaluation for injury. As we have discussed multiple times in this course, taking a thorough history is the foundation of a good evaluation, regardless if you're an athletic trainer, physical therapist, chiropractor, occupational therapist, or even a doctor. A good history should help you to narrow down the rest of your physical assessment for the patient. Asking questions regarding a patient's level of pain is a good place to start. Many times, thoracic injuries are associated with pain, either during the inspiration, the expiration phase of breathing, or both. Rib injuries and spine injuries are commonly associated with pain during coughing and sneezing due to the increased intrathecal pressure during those activities. Intrathecal pressure is the pressure of the fluid, or the cerebrospinal fluid, in the space around the spinal cord and brain. It protects the structures beneath and carries nutrients to the brain and spinal cord, as well as carrying enzymes. Also talking about general medical conditions which may affect the individual. Exercise-induced asthma is a narrowing of the airways in the lungs triggered by strenuous exercise. It causes shortness of breath, wheezing, coughing, and other symptoms during or after exercise. The preferred term for this condition is exercise-induced bronchoconstriction. This term is more accurate because the exercise induces narrowing of the airways or bronchoconstriction, but is not the root cause of asthma. We may also have individuals who have severe asthma attacks. They may have associated costochondritis. If you have asthma, a respiratory condition that causes breathing difficulties, you may experience chest pain. Chest pain is most common before or during an asthma attack. The discomfort may feel like a dull ache or a sharp and stabbing pain. Some describe it as if they have a heavy brick sitting on their chest. While chest pain is not unusual in people with asthma, it may be signs of other conditions as well, so we need to be careful. Chest pain or tightness is common in people with asthma. In one emergency department survey, 76% of people with asthma reported chest pain. If you have asthma, your immune system can cause your airways to become inflamed and swollen when you're around certain irritants, which may lead to chest tightness, pressure, and pain. Studies show that chest pain, along with other non-respiratory symptoms, frequently occur during or before an asthma attack. If you experience chest pain after an asthma attack, it could be because you're sore from the coughing, deep breathing, or other symptoms you experienced. Coughing, deep breathing, and changing positions can all worsen chest pain in people with asthma. This may result in costochondritis over a long period of time. Herpes zoster, also known as shingles, is an inflammatory condition characterized by blistering, itching, painful, and a burning rash. Shingles is caused by activation of the varicella zoster virus. Varicella zoster is the same virus that causes chickenpox, usually in younger children, and shingles only occurs in people who have already had chickenpox. Once a person has had chickenpox, the virus remains in the nerve cells near the spine. Chickenpox will never reoccur if the virus is reactivated. Instead, a condition far worse than chickenpox develops, which is shingles. From 2000 to 2006, there were an estimated 10 out of 1,000 people over the age of 50 who had contracted shingles. The average age for contracting shingles is 68 years of age, and both men and women are equally as likely to contract the condition. Some risk factors for shingles. Chickenpox is the major predisposing factor to shingles, which usually follows a decade later. Chickenpox is highly contagious, and up to 97% of people have experienced chickenpox by age 40. Everyone who has had chickenpox produces varicella antibodies that remain in the nerves throughout their life to fight the virus. The reactivation of the virus most commonly occurs in people who have a decreased immunity. This includes the elderly, people with diseases that affect the immune system like HIV, and people with diseases that require treatment which has been effective on the immune system, such as treatments for chemotherapy for cancer, people with neoplastic disease, or organ transplant recipients. Scoliosis is a sideways curvature of the spine, which occurs most often during growth spurts just before puberty. While scoliosis may be caused by conditions such as cerebral palsy and muscular dystrophy, the cause of most scoliosis remains unknown. Most cases of scoliosis are mild, but some children develop spine deformities that continue to get more severe as they grow. Severe scoliosis can be disabling. An especially severe spinal curve can reduce the amount of space within the chest, making it difficult for the lungs to function properly. Children who have mild scoliosis are monitored closely, usually with x-rays, to see if the curve is getting worse. In many cases, no treatment is necessary. However, some children will need to wear a brace to stop the curve from worsening. Others may even need surgery to help the scoliosis from worsening and to straighten severe cases of scoliosis. Signs and symptoms of scoliosis may include uneven shoulder height, one shoulder blade that appears more prominent than the other, uneven waist, one hip higher than the other, and if the scoliosis curve gets worse, the spine will also rotate or twist in addition to curving side to side. This causes the ribs on one side of the body to stick out further than the other side. The Adams Forward Bent Test. The purpose of this test is to identify individuals with scoliosis. We start with our patient standing. We have our patients bring their hands together and then bend forward at the waist as far as possible. Look for one side of the rib cage to be higher than the other next to the vertebral column. The convex side is the one with the rib hump. So why is this test important? A rib hump forms on the side of the convexity because as the vertebrae are laterally flexed to one side, they must also rotate to the opposing side due to the facet alignment. Facets are aligned to the frontal plane with a forward tilt of approximately 15 to 25 degrees. During lateral flexion to the right, the inferior facet of the superior vertebrae slides inferiorly and posteriorly on the right and superiorly and anteriorly on the left, which results in rotation as well. The ribs attached to the vertebrae follow the rotation and appear to stick out on the ipsilateral side of convexity. It is important to identify individuals at risk for severe development of scoliosis as early as possible, and it may impact your treatment and plan or referral. Kyphosis is an excessive outward curvature of the spine, causing hunching of the back. It is most common in older women and often related to osteoporosis. Some people with kyphosis have pain in the back and stiffness, while others have no symptoms other than an exaggerated forward rounding of the back. Severe kyphosis can cause pain and become disfiguring. Treatments may include medication for pain, physical therapy, and sometimes surgery. Pectus carinatum is a rare chest wall deformity that causes the breastbone to push outward instead of being flush against the chest wall. It is also known as pigeon chest or keel chest. When the chest wall develops, the cartilage that connects the ribs usually grows flat along the chest. In the case of pectus carinatum, this cartilage grows abnormally, causing unequal growth in the areas where the ribs connect to the sternum. This causes the outward appearance of the chest wall. More often, pectus carinatum develops during childhood and gets more pronounced as children go through puberty. In some cases, it may not be noticed until a child goes through their adolescent growth spurt. Pectus carinatum affects 1 in every 1,500 children and affects 4 times as many males as it does females. It is the second most common chest abnormality seen in children. Pectus excavatum is a condition in which a person's breastbone is sunk into their chest. In severe cases, pectus excavatum can look as if the center of the chest has been scooped out, even leaving a dent. Pectus excavatum is most noticeable shortly after birth and typically worsens during the adolescent growth spurt. It is more common in males than it is in females, and it may be associated with genetic or connective tissue diseases. Pectus excavatum does not usually require treatment, although physical therapy may help if symptoms develop. Rarely, surgery is needed to correct the condition. The bones or vertebrae that make up your spine are very strong, but sometimes a vertebrae can fracture, just like any other bone in our body. Vertebral fractures are usually due to conditions such as osteoporosis, a condition which weakens the bones, a very hard fall, excessive pressure, or some kind of physical injury. When a bone in the spinal column collapses, it's called a vertebral compression fracture. These fractures happen most commonly at the thoracic spine, or the middle portion of the spine, particularly in the lower vertebrae of the thoracic spine. Compression fractures of the spine usually occur at the bottom part of the thoracic spine in T11 or T12 and the first vertebrae of the lumbar spine, or L1. A fracture can occur when the bone actually collapses and the front or anterior part of the vertebral body forms a wedge shape. A chance fracture is a type of vertebral fracture that results from an excessive flexion of the spine. Symptoms may include abdominal bruising, also known as seatbelt sign, or less commonly, paralysis of the legs. Chance fractures are also associated with transverse fractures in the spinous process. About 50% of chance fractures are also associated with intra-abdominal injuries. There's a case study for an unusual mechanism of injury resulting in a thoracic chance fracture in a rodeo athlete. This individual was injured while riding. In order to repair his spine, he had to have multiple rods and plates placed in his spine to help stabilize the chance fracture. This individual is back riding following successful surgery of a chance fracture. Classifications of vertebral fractures by the Gannat semi-quantitative method. Asymptomatic and symptomatic vertebral fractures can be diagnosed using the Gannat semi-quantitative method, which requires a 20% decrease in vertebral height either from the anterior, the mid, or the posterior dimensions, estimated visually to diagnose a vertebral fracture. The historical height loss can be calculated as the difference between a patient's tallest recalled height, or the TRH, and the current measured height, the MH. Vertebral fractures resulting from osteoporosis can often lead to loss of vertebral body height, in turn causing a decrease in stature, or us feeling like we're losing our height. To perform the historical height loss assessment, we first assess the patient's height. The patient is then asked about their maximal historical height, how tall they think they've ever been. And then the clinician subtracts the maximum historical height by the current patient height. The final value is then used to determine the likelihood of a thoracic compression fracture. Rib fractures are an injury which occurs when one of the bones in the rib cage cracks. There are more than 3 million cases of fractured ribs per year in the United States. A fractured rib is usually the result of a fall or an accident, but may also be the result of prolonged coughing, and sports with repetitive movements such as golf can also cause rib fractures. Symptoms include pain when taking a deep breath, pressing on the injured area, or bending and twisting the body. In most cases, fractured ribs usually heal on their own in 1 or 2 months, and pain relievers can make it easier to breathe deeply. Other possible findings include tenderness to palpation over the site of the possible fracture, crepitus if the bone really is fractured, torso and arm movements increasing pain, a splinting posture either by holding the injured area or by leaning towards it. The patients usually do not develop neurological signs, so they're not going to have a whole lot of numbness and tingling, mostly just localized pain, but they will have a positive rib compression test. The rib compression test, it is important to note that it is contraindicated if lung trauma is suspected. The rib compression test is performed by having our patient standing. They may be seated or on the edge of the table as well, with the arms hanging by the sides. The examiner stands to the side of the patient with the hands on the anterior and posterior aspects of the rib cage. The examiner then pushes the hands together to compress the rib cage and then releases the pressure. A positive test will result in pain or point tenderness with compression of the rib cage. This may indicate the possibility of a fracture, a contusion, or a costal-chondral separation. We have our patient again. The examiner uses both hands to compress the lateral sides of the rib cage inwards towards the sternum. A positive test will result in pain or guarding. Positive test indicates possible rib fractures. It is important to do an anterior-posterior rib fracture test prior to doing a medial lateral. In the event that a rib actually is fractured, we want to make sure that the ribs are not going internally towards the lungs if we suspect a fracture. The chest cavity contains vital organs and is protected by a bony rib cage. Rib fractures that are single and non-displaced are classified as hairline fractures or simple fractures. Ribs usually fracture at the point of impact or in the back where structurally they are the weakest. More complex fractures can cause the edges of the bones to become misaligned and displaced. A serious condition involved with rib fractures is called flail chest, and it occurs when multiple adjacent ribs are broken in multiple places, separating a segment which is free-floating and moves independent. The most common ribs for fractures are ribs 7 through 10. Fractures of the first and second ribs are rare, but may be associated with serious damage to the brachial plexus of the nerves, the subclavian vessels, or associated with head, facial, or thoracic aorta injuries. A lower rib fracture is more likely associated with injuries to the diaphragm, liver, and spleen. When a rib tears away from the cartilage, the injury is called a costal-chondral separation. It may result from a blow to the ribs, a fall, or landing hard on your feet. It might even be caused by a forceful coughing or sneezing. Irritation of a rib is called costochondritis. Sometimes crepitus and excessive movement is palpable. We want to make sure that we're ruling out a rib fracture and ruling out internal damage to organs as well. We will end our lecture here and we'll catch up with you after we return from Thanksgiving. I hope you all have a happy and safe Thanksgiving. Can't wait to see you when we return.